Okay. Hi, everyone. For those of you who don't know me, my name is Andrea Burke. I am an oral surgeon, and I work at the National Institutes of Health. And today I'll be talking about fibrous dysplasia and another disorder, cherubism, as well as the craniofacial and dental implications of both of these. So here are some commonly asked questions that we get. How is craniofacial fibrous dysplasia or cherubism diagnosed? When and how do these lesions show up? Where are most of these lesions located? And do more of them develop over time? What kind of functional problems can occur? And how do you treat these? So before starting anything, I know that we didn't put up a nice slide of the skull, but I just wanted to talk about the craniofacial anatomy since I'll be talking about some of the bones. And as you can see, there are a lot of bones in the craniofacial skeleton. For instance, the bones around your eye, there are 7 of them. So the ones I'll be sort of focusing on here in green is the frontal bone. In here, in yellow, in this picture here, is the maxilla, or the upper jaw. In blue, on the bottom, is the lower jaw, or the mandible. And here, in white, is a bone called the zygoma, and that's the bone that gives your cheek sort of the structure, your high cheekbones. So just a word about prevalence. As we heard before, monostotic fibrous dysplasia is reported to be the most common, but unfortunately, these case reports are mostly inconclusive, and in a lot of these studies that were done, these patients hadn't had thorough workup, so we really don't understand the extent of the disease. And also, as we heard, that in the most common locations are the craniofacial bones, the proximal femur, the pelvis, and the ribs. So where are most of these lesions located in the craniofacial skeleton? So in monostotic fibrous dysplasia, and when I say monostotic, again, I'm referring to either one bone, or because the face has so many bones, it's one region of bones. So this area called the zygomatico-maxillary complex, also referred to as the ZMC, is the area that's most commonly involved, and that's this area in blue, and it sort of extends over here to the maxillary bone, and sometimes it can include the temporal bone, part of the frontal bone, etc. But that area is sort of referred to also as monostotic, unless you have disease elsewhere in the body, in which case you have polyostotic disease. So in polyostotic fibrous dysplasia and the McCune-Albright syndrome, the craniofacial region is involved in about 90% of the cases, and the anterior cranial base, which we keep referring to, which is sort of this area in green, is involved in about 95% of the cases. And 84% of patients with craniofacial fibrous dysplasia have lesions in either the upper jaw, lower jaw, or both, and the upper jaw is more common than the lower jaw. As far as cherubism goes, many of you may be familiar with it, might not be familiar with it, but it is a rare hereditary benign bone disease with an autosomal dominant inheritance. And what is autosomal dominance? If you haven't heard of that, that means that your parents, you just need one affected copy of the gene from one of your parents in order to have the disease. And most of these cases come from a mutation in this gene, the SH3BP2 gene, which is located on chromosome 4. And this disease can go from generation to generation if it is autosomal dominant. However, in some cases, we've seen non-familial cases or sporadic cases that have popped up. And one of the important things in diagnosing cherubism is that it is almost always bilateral, meaning that it's on both the left side and the right side, and it's usually in the upper jaw, lower jaw, or sometimes both. It can become noticeable in early childhood, specifically around the ages of 2 to 7 from studies, and it grows progressively until puberty. But then in puberty, the lesions regress, start to fill with bone, and remodel, and that means that the bone sort of restructures itself, and this occurs from the studies that we've seen until about the age of 30, and then it sort of just stops. So here's a patient with cherubism, and usually the lower jaw is more commonly affected. There are 3 different classifications of cherubism. The first is quiescent, which means that the growth has sort of ceased or stopped, and this usually is seen in older individuals. Then there's non-aggressive, typically seen in teenage population, aggressive in younger children, and this is usually where you see the large, rapidly growing disease, and it may cause things like tooth displacement, root resorption, or perforation of that cortical lining of bone, which is the shell we were talking about. And it can affect the normal eruption of teeth as well as your bite. And so here in this patient, she had quiescent fibrous dysplasia when we saw her, but you can still see some residual bilateral facial expansion. And inside her mouth, she's missing a couple of teeth, both in the front and the back, and has a little bit of, her bite is off. But what we see in this disease is that the symptoms can range anywhere from being almost non-detectable to having a gross deformity to even displacing your airway or your trachea and having visual and hearing problems. So how do most of these lesions show up? We find most of them in the craniofacial skeleton incidentally. And incidentally means that maybe you're getting an x-ray taken for some other purpose, you're at the dentist's office, or you're getting your wisdom teeth taken out, and that's typically when we will find them. The other way is just asymmetry, it's not even something that maybe parents or close family members will notice because you're seeing the child on a daily basis. But when the physician sees the child, they may notice some asymmetry, maybe at the eyes, the forehead, the cheeks, nose, jaws, and the teeth are typically not displaced in fibrous dysplasia, which is a difference between fibrous dysplasia and cherubism. There may be functional changes, nasal congestion, as we mentioned, epiphora or overflowing of tears, headaches or bone pain, paresthesias and seizures, but all of these last few things are very, very rare. And the diagnosis is typically made based on a good history and physical exam, as well as in cherubism having a family history. But we see this asymmetry and swelling, which are the most common complaints in the facial skeleton. And then we can do a CT scan, which is the gold standard of imaging, as well as a bone scan, which will show us what the distribution of the lesions are and how they're progressing over time. Dental x-rays, genetic testing, as Dr. Collins mentioned, the GS-alpha protein mutation, we can check for that in affected tissue, or we can do genetic testing for the SH3BP2 mutation, lab values, plus or minus biopsy. And I should just point out that sometimes the biopsy is not necessary because you can actually make the diagnosis based on a good physical exam and the radiographs. So I just wanted to mention why we're combining fibrous dysplasia and cherubism. And the reason is that they're sort of, you could think of them as cousins of the same disease process. A giant cell lesion, a giant cell tumor, is actually a bone tumor which is comprised of these multinucleated giant cells. And as you can see this very closely resembles the osteoclasts, or those bone-eating cells that you were seeing previously. And this is a gross specimen on top of what one of these lesions might look like. It sort of has like a purplish hue, and that's usually because of the increased number of blood vessels in these specimens. But just pathologically speaking, if somebody showed this to me, I wouldn't be able to tell if this was a giant cell tumor, if this was something from somebody who had cherubism, if this was something from fibrous dysplasia, because they all look so much alike. And also on x-rays and in histology, meaning these microscope slides, they also look similar. So here's a patient with craniofacial fibrous dysplasia, and I just wanted to point out a couple of findings that we're looking for when we do the exam. So this patient has McCune-Albright syndrome, and these patients tend to be the most severely affected, particularly if they have a growth hormone excess. So when I'm looking at this patient, I'm immediately noticing that she has an asymmetry of her forehead with some protuberance here on the right side. Her eyes are not level, and her right eye actually is bulging out slightly. This is something that we call proptosis. In addition, you can see that the angles of the corners of her mouth are not the same level, and her teeth actually are almost slanted, and this is something that we call a cant. And you can also appreciate that she has this swelling in the right maxilla over here over the teeth. And this is a little boy with cherubism, and the way cherubism got its name was because the lesions that occur in the upper jaw would sometimes push on the eyes, and it would make these patients look like they're almost looking up toward heaven and give them an angelic look, so hence the name cherubism. But you can see many of these same findings, and in this disease, oftentimes patients will have submandibular or neck swelling from the inflammatory component leading to the bilateral facial swelling. And here are some plain x-rays. I know we saw some of in the long bones, but as we talked about before, these are really non-specific. We can see that there's something wrong in the slide with fibrous dysplasia, but it's sort of amorphous. We can't really make out the details. In dental x-rays, however, these are typically a good way for diagnostic purposes, although, as I said, CT is really the gold standard. And here you can see down here, there's sort of this mixed, it almost looks like moth-eaten area, and this is a cherubism lesion. Over here, we can see there's a nice sinus, which is a little bit darker over here, and this is the remnant of the sinus, but then there's this area of ground glass appearing bone in fibrous dysplasia. And when we're talking about CT scans, just to be clear, there are 3 different planes that we can perform this scan in. And these cuts are done in what's called the axial or the transverse plane, and that's as if somebody's cutting me across this way, and they're looking up from my feet at my head. And you have to keep in mind that this is the right side and this is the left side when we're showing you these scans. So here again, similar to what Dr. Kim was showing you, this is the maxillary sinus, and this is being obliterated as compared to the normal that we see over here. And here's an example of a bone scan, and I'd just like to point out that here we can see monoostotic disease. And the important thing to notice about the fibrous dysplasia on CT is that it changes over time. So it's not always the same thing that we're seeing. And here you can see 3 very typical images of fibrous dysplasia. The top is showing you the more uniform ground glass that we refer to appearance. And the middle is showing more of a mixed, meaning that there's some almost pitting, it looks like, or holes within the ground glass. And then the lower shows these areas of what we call lucency, or more lytic. They're clear on the x-ray. And then you can also get things like cystic components, like we talked about the aneurysmal bone cyst. But it is important to notice that this does change over time in patients. And here are just some examples of 3D imaging that we can get on patients with cherubism. And as you can see, this one here is quiescent, but you can see the residual lesion in the upper jaw, in the lower jaw, and in this little boy, this sort of moth-eaten pattern of his jaw as the giant cell lesions eat away at it. And we briefly went over this as well. When do these lesions present? Basically, 90% of lesions, based in this study by Hart et al., were determined to be present prior to the age of 15. And 90% of all craniofacial fibrous dysplasia lesions were detectable on bone scan by the age of 3.4. No new craniofacial fibrous dysplasia lesions were reported beyond the age of 10. So this goes back to what Dr. Collins was saying, which is that once you have these lesions, you do not acquire more of them as you get older. And here's an example of this little girl. This is a patient of Dr. Collins, and she was followed here over a period of about 10 years. And here she is at 5 and 15. And we're just showing on CT scan, and this is the area of the anterior cranial base. Again, this is an uninvolved CT scan. We can see the ground glass appearance of her fibrous dysplasia and how it's actually changing over time. But it's important to point out that if you look at her over the almost 11-year time span, her facial proportions are not changing. You don't see that, despite the fact that the lesion is changing, she actually looks like fairly normal. So, and then here, as we move to the maxillary sinus, we can see again she had obliteration here and how it starts to develop into more of a mixed pattern. And then in the lower jaw as well, we can see. And then finally, in her lower jaw, the mandible, it went from a ground glass appearance to more of a mixed appearance here. And this is just showing a uninvolved mandible for your reference. So will more lesions develop? Like I said, more lesions are not likely to develop. But lesions can change over time, as we said. So this suggests a change in the activity of the bone cells as they function over time. And the most dramatic changes typically can occur around the 2nd decade, and the reason why we think this occurs is because of puberty and hormonal changes. The lesions can become associated with rapid growing lesions, such as aneurysmal bone cysts, which we talked about, and very, very rarely can they transform to malignancy. But it's important to remember that any kind of growth hormone excess or other kind of endocrinopathy can exacerbate these lesions. As far as functional problems, first I'm just going to refer to the vision loss. So polyostotic fibrous dysplasia was frequently noted to be seen in anterior cranial base involvement, and it was also noted to be very close to the optic nerve. So studies back as far as 1968 showed that the most commonly reported neurologic symptom was vision loss. And there were also reports of sporadic vision loss. So the assumption based on these studies was that if you have fibrous dysplasia around your optic nerve, this can lead to blindness, and therefore we need to do a surgery to prevent this. So here's that little girl again, and here's her 3T CT imaging as she's getting older. And here we can see her optic nerve canal over time, and that's what these arrows are pointing to, that circle. And you can see that over the period of time, despite the fact that she has had, fibrous dysplasia for 11 years at this point, that the optic nerve canal has not changed. So we see statistically significant narrowing of the optic canal, but the majority of patients who have been studied in the NIH cohort had normal eye exams. So therefore, it was noted that prophylactic optic nerve compression was not recommended based on the radiographic findings alone, since these did not correlate with vision loss. So basically, this means that if you do have craniofacial fibrous dysplasia and it is involving an area that is around your optic canal, you should see an ophthalmologist or a neuro-ophthalmologist on a regular basis for exams. But just based on the radiographic findings on the CT scan, if you have narrowing, which almost all patients do, it doesn't mean that you need to have a surgery. So, as far as dental problems go, because of the often complex types of patients with fibrous dysplasia, McEwen-Albright syndrome, cherubism, many practitioners will balk at treating them. But I'm here to tell you that patients can receive dental therapies, restorations, root canals, extractions without making these lesions worse. There have been noted in previous studies that there's an increased rate of cavities in patients with fibrous dysplasia. This may mean that they need more frequent hygiene visits, perhaps using an electric toothbrush or topical fluoride has been suggested, but I think these studies are still ongoing. And then briefly, I know we'll talk about this later, there can be medication-induced osteonecrosis of the jaws, which is very rare, despite the higher doses in fibrous dysplasia patients. So as far as some of the dental anomalies that occur, this is, again, the NIH cohort, and it was seen that there were higher levels of attrition or tooth wear, taurodontism, which means that the pulp chamber of the tooth is actually wider than normal, and this was only seen in those patients who had growth hormone excess. Enamel hypomineralization, which is a problem with the top layer of the tooth. Enamel hypoplasia, which means that the enamel doesn't form as well, and this can lead to cavities. And then tooth displacement or rotation or missing teeth. But again, a lot of these studies are ongoing. As far as dental problems in cherubism, while development and tooth eruption appear to be normal in fibrous dysplasia, they are significantly affected in cherubism. And there's an impact on development and eruption, which requires, good dental and oral surgical care from the time that these children are young. The arrangement of the primary teeth can be disrupted. The permanent teeth, the buds that are growing in the bone as these children are developing, can be affected. You can have absent teeth, abnormally shaped teeth. The roots might not be normal. And then you may need to extract teeth in cases where, as you can see in the bottom, the teeth appear to be sort of floating in these lesions and they're not growing normally. So in some of these instances, children may be required to wear a prosthesis if they have areas of missing teeth or spaces, and this can improve function and aesthetics as they are growing. As far as orthodontic therapy, the majority of patients with fibrous dysplasia and cherubism have malocclusion, which means a disorganized arrangement of the teeth. So this can be, orthodontic treatment can and should be performed in these patients, but studies have shown that this may take longer in fibrous dysplasia bone and that relapse may be more common. There have been some studies that have said that we should wait until children have reached what's called skeletal maturity, or when they've stopped growing. But my personal feeling is that it's good to get in to see an orthodontist early, And even if you're not putting braces on a child, you're at least preparing for when you're going to do that. And I think that as far as cherubism goes, with children often missing teeth, it's definitely necessary to maintain space and seek orthodontics early. As far as dental implants, the literature is very limited on this. I'll say that. But bone healing and integration of the implants does occur in fibrous dysplasia bone, although the bone quality is noted to be different. There was a reported case in a woman with McCune-Albright syndrome, and after 5 years of follow-up, her dental implants had maintained and were still functional, but it should be noted that her lesions were quiescent, meaning that they were no longer growing, and the dental implants were very long. So probably both of these factors contributed to that. So therefore, it's recommended that implants, particularly if you're considering implants in children, need to be placed after skeletal maturity and once the growth of the fibrous dysplasia lesion has subsided. So finally, how do we treat craniofacial fibrous dysplasia from a surgical standpoint? The management depends on the age, then skeletal maturity, as well as clinical findings. And we can also group these lesions, as we did with cherubism, into quiescent, non-aggressive, aggressive. And really, some of the indications are going to be rapid growth, pain, paresthesia, etc. But for the majority of patients, we're going to monitor them, observe them with close follow-up. So clinical assessment is very important, taking various measurements, including photographs, sensory nerve testing, and then doing a maxillofacial CT. And this depends on clinical findings. So some surgeons may want you to have a maxillofacial CT on a yearly basis, but then as the child starts to get older, then maybe you can go to a 2-year basis or a 5-year basis. And again, this is really on an individual basis. And then medical management, which we'll talk about more for the bone pain. Indications for surgery, as I said, we really only biopsy if the diagnosis is questionable. If we could get a good analysis based on a good physical exam and on radiographs, a biopsy is not necessarily indicated. If there's concern for aggressive growth, atypical or unusual behavior, such as an aneurysmal bone cyst, this is an indication for surgery. And the different surgical options that we perform, we refer to it as contouring, or you may have heard this term recontouring, and this really should be avoided until growth has stopped. And the reason for that is mainly because if you go in, you remove the bone, it can grow back. And sometimes it can grow back more aggressively. Resection and reconstruction, again, are not typically performed, but there are, in very rare cases, a fibrous dysplasia lesion which you could entirely remove. And if that is the case, it can be resected. Reconstruction is coming more if you perform a radical resection in cases that would warrant it. Orthognathic surgery is a type of surgery that's done in congruence with an orthodontist to correct malocclusion or facial or dental asymmetries. And this has been done in fibrous dysplasia bone, and there are no documented contraindications, which means that if the bone is not actively growing, it's okay to do this. And I know we mentioned a little bit about the plates and screws that we use. We do use titanium plates and screws, and these have been shown to integrate well, and the bone heals normally, so these are not matters that as a craniofacial surgeon we worry about. And the bone healing has been documented to be normal in such patients. However, as I mentioned, there is evidence that if you do operate on these lesions, they can regrow after surgery and even become aggressive in some cases. And I guess the point is we can't predict or prevent regrowth. So when people come to me and they ask me, can you remove this? I say, yes, I can remove it, but we have to talk about, the pros and cons of this and what's going to happen, and are you willing to live with the risk of having it regrow? And then lastly, surgery is not typically indicated for cosmetic purposes for the reasons that I just said, but this is really dependent on a case-by-case basis again. So if you are a patient and you have, your lesion is quiescent after a period of time, it doesn't seem to be growing, it's sort of a, it's a personal choice. So just something to keep in mind. And here's a patient that I just wanted to point out as I was mentioning lesions growing back. So this is her progressing over time, and between the second and third picture here, she had a recontouring of this lesion, which is here in the left maxilla. And unfortunately, it grew back, and it grew back very aggressively. So she needed to have a reoperation later, mostly because we were concerned that there was another disease process going on. And then finally, you can see after she had the second reconstruction, this is her photograph here. And in doing that, we also removed the fibrous dysplasia in her palate, and you can see how her dental arch has kept a good contour, and how now she's ready to have dental implants at some point after she stops growing. As far as cherubism, again, the management really varies on the extent of the disease and the clinical behavior. Conservative treatment is almost always the case, unless the lesion is causing serious disfigurement or expansion, or we're worried that something else is going on. But for the most part, the disease is what we call self-limiting, and that means that it stops growing over time and involutes. There is medical treatment for the giant cell lesions associated with cherubism, and that includes medications such as interferon, calcitonin, and newly anti-inflammatory agents. So, just want to say thank you to everybody.